Next is thoracic region. It has 12 vertebrae, and the normal curvature of the thoracic spine is kyphosis. The major function is the attachment of the ribs and rib cage, which take part during respiration. The costovertebral joint and the costotransverse joints are the two joints that are distinct feature of thoracic spine, where the ribs actually articulate with the thoracic vertebrae. Most of the rotation takes place at the cervical and the thoracic spine, and less at the lumbar spine. The flexion and extension, again, you can refer to your reference sheets for the values for the measurement of the flexion and extension, side bending to the right and left, and same as the rotation. During the bad posture or certain pathologies such as osteoporosis, and in case of any vertebral fracture, people may develop a bad posture of forward head, a rounded shoulder, and increased thoracic kyphosis. With the increased thoracic kyphosis, the posterior thoracic muscles, they become stretched and they don't have enough strength to actually have the scapula be in the correct posture, and then eventually it will lead to reduced strength of the shoulder. At the lumbar spine, we have L1 through L5, 5 lumbar vertebrae. They are the vertebra with the largest vertebral body, L5 being the thickest vertebra in the whole body. Out of all the discs in the spine, the disc at L5S1 takes the most of the pressure or weight of the whole body. We determine the lumbar spine curvature by measuring the lumbosacral angle, which is the angle between the horizontal line and the line drawn at the superior aspect of the sacrum. So the line between L5S1 or the superior aspect of the sacrum and the horizontal line determines how much lumbar lordosis is there. Excessive lordosis, or it can be reduced lordosis or reduced lumbar spine, or it can be called as low flat back. If there is an angle, increased angle at lumbosacral angle, then it results into increased pressure on the facet joints in the back and also on the discs, resulting into the degenerative disc and the joint disease. Ligamentum flavum and anterior longitudinal ligaments are the two ligaments that provide support to the lumbar spine anteriorly, and ligamentum flavum being inside the spinal canal also provides the support so that the lumbar vertebra, they do not slip anteriorly on top of each other. Iliolumbar ligament is a ligament between the transverse process of the L4 and the pelvis, and it also holds the lumbar L4, especially in particularly back, which also resists any excessive movements of L5 on S1. But it is the source of the low back pain. This iliolumbar ligament, one of the sources of the low back pain when it gets injured. Muscles, the first we would like to cover is thoracolumbar fascia. At the sacral region, we have 5 fused sacral vertebrae and 4 coccygeal vertebrae. Sacrum is a triangular shaped bony structure with superior base and a pointed apex, which is pointing directly inferiorly. Sacrum makes a joint with the ilium and that joint is called sacroiliac joint. It is a synovial joint, and there are many ligaments that actually hold this joint together. The basic function is to disperse the compressive forces. Movements that take place at the sacrum are very important, and they are somewhat difficult to understand. If we just know our reference points during these movements in mind, we can easily visualize the movements that are taking place at the sacrum or sacroiliac joint. So the first movement is called nutation. The base of the sacrum is our reference point. When it moves anteriorly and inferiorly, it is called nutation. When it moves anteriorly and inferiorly, apex will automatically move posteriorly and superiorly. The axis is right at the sacroiliac joint. Pelvis, on the other hand, moves in the opposite direction. So in the pelvis, we have anterior superior iliac spine as our reference point. So here, the ASIS will move superiorly and posteriorly during nutation. During counternutation, the base of the sacrum moves posteriorly and superiorly, whereas the apex moves anteriorly and inferiorly, whereas anterior superior iliac spine will also move inferiorly. When we study pelvic tilts, and we did discuss those during the hip joint lecture, the pelvis, we use the reference point, of course, the ASIS or anterior superior iliac spine. During anterior pelvic tilting, it moves inferiorly, and there's increase in lordosis at the lumbar spine with the extension. During posterior pelvic tilting, the anterior superior iliac spine moves superiorly, and there's a decrease in lumbar lordosis, such as when you are sitting. We'll discuss some of the muscles of the spine, starting with the cervical spine first. Upper trapezius, on both sides, the right and the left upper trapezius. These are the two muscles that are attached to the cervical spine and the scapula and the thoracic spine. So if these two muscles work together or contract together, either they will cause cervical spine extension, or if the cervical spine is stable, they will cause the bilateral shoulder elevation or scapular elevation. If the right upper trapezius contracts, it will cause right cervical spine side flexion. And if the left upper trapezius contracts, then it will cause left cervical spine side flexion. Our next muscle is the levator scapulae. We remove the trapezius and we look deep inside. This is the levator scapulae, which is attached to the superior angle of the scapula and to the cervical spine. If it contracts, it lifts the scapula. Next group of muscles are the erector spinae. You don't have to memorize all these names. You just have to remember, if they contract bilaterally, they cause the thoracolumbar extension. If one side contracts, they will cause a lateral flexion of the same side. Eccentrically, they control the trunk flexion. In other words, they are holding the spine and gradually letting it go as you bend forward to touch your toes. Another important muscle attached to the spine is the quadratus lumborum, which we call the hip hiking muscle. So if you are standing and you lift your one side hip, then you are hiking the pelvis of the same side of where you are actually contracting the quadratus lumborum muscle. On the front or the anterior part of the spine, the first group of muscles are the cervical scalenes. They are the three groups of muscles, the anterior, middle, and the posterior. When they contract, they cause ipsilateral cervical lateral flexion with the small degrees of rotation. So you just have to remember for scalenes, if they are contracting, they cause the same side flexion of the cervical spine. If they both contract, they cause small amount of cervical flexion. Another most important muscle in the cervical spine is the sternocleidomastoid, or what we call in short SCM. It causes the flexion if it contracts on both sides. It causes the cervical spine flexion, and in particular the lower cervical spine flexion. If it contracts on one side only, then it causes the lateral flexion of the same side and the opposite cervical rotation. And that is a very important muscle of cervical spine, a very important function of this muscle. Uh, with the SCM, if it gets tight, or if it gets contracted, especially in newborn, it may lead to torticollis with the typical pattern of same side flexion and opposite rotation of the cervical spine. At the thoracolumbar spine, we have the rectus abdominis, and that causes the trunk flexion. After that, we have the oblique muscles, the external and internal oblique muscles. The transverse abdominis muscles is the deepest abdominal muscle. It is these four abdominal muscles which contribute towards the spinal stability, and along with many other muscles, but anteriorly, these are the four abdominal muscles that actually provide the support, especially corset or lumbar belt kind of support. At the posterior aspect, we have multifidi, which are attached to many spinal segments and or the vertebrae, and also to the sacrum. And it's a reminder, sitting in a bad posture for a long period of time is when all the muscles in the back, especially the spinal extensors, they will get overstretched and resulting into a fixed posture, which is a forward head posture in this case.